Thank you all for being here. I know there are a lot of really good competing talks, so I'm happy to see that you're here. I wish that this talk was a 1 minute talk where I just told you the cure for calcinosis, because that would be a much better talk. We are going to talk about many things, including the science of calcinosis, potential treatments that we use, some of which we find to be helpful in some cases. Although there is no FDA approved treatment for calcinosis, it's just really a bear of a problem. Scleroderma is bad enough. And then this, even if it's one spot that's on the thumb or on the index finger, you go to pick up a spoon and it's there, it's just in your face. So when I was a fellow at Johns Hopkins, I'm at Northwestern now, Northwestern in Chicago, as she clearly pointed out, is it kind of an anachronism because it's nowhere Northwestern. But it is, when I was a fellow at Johns Hopkins, this was one of the areas that I really wanted to push to study, because it so affects people's lives. And it's been a challenge to try to convince people of how big of a problem this is, because I think a lot of times we think about the lungs, here at Northwestern, we do a lot on the gut in scleroderma. And this, for people who've not experienced it or who've not taken care of people with calcinosis, a lot of people think it's a nuisance. You deal with it, but it's more than that. It is, some people have it where it is on the foot and it's like you're walking on rocks. I mean, could you imagine if you had a rock in your shoe that you could never get out? That would drive you mad. Some people have it on the buttocks and they can't sit comfortably on a cushion. And so there's a lot of ways. It's, sometimes scleroderma is not always, there's different things affect people in different ways. And there's things that can threaten people's lives. And those are clearly very important for us to identify, treat, study. But then there's the things that affect what you do every day that just interfere with your life. And calcinosis is a big thing that interferes with your life. The picture I have up here is a little bit of a preview, is from one of the studies that we did. That is actually a sodium fluoro PET scan of a pelvis of someone with scleroderma. So we're going to go into that. So I have been a consultant for Cabaletta Pharmaceuticals in the past 2 years. They're one of the pharmaceutical companies that's been doing the CAR T-cell trials that we're very excited about. So that's just a disclosure. It doesn't, I don't think, have too much directly do, but it's always a good idea to tell people where you got money from. Okay. So we're going to talk about, first of all, calcinosis overview. What is it? How does it form? With the caveat that we wish we had more comprehensive information. We wish this was as well studied as, any other thing in scleroderma, but it's a little bit understudied. So, and we're talking about the science of calcinosis. And then part 3 is going to be the treatments that we use at Northwestern and other places. Okay, so the key questions we're going to answer would be, what is scleroderma-related calcinosis? What do we know about what causes calcinosis? And what do we know about how to treat calcinosis? Okay, part 1, calcinosis overview. So what is scleroderma-related calcinosis? So scleroderma-related calcinosis is not something that happens because you ate too much calcium. And it's not something that happens because the calcium got too high in the bloodstream. There are types of calcifications that can happen because of that. So for example, in people who are on dialysis may get high levels of phosphorus, and that phosphorus and calcium may form in the blood vessels and deposit calcium. That is a separate complication. So people can get calcifications because of high calcium and phosphorus levels. In scleroderma, that's not generally what this is. Now, there are some people who can have high calcium in the bloodstream. That needs to be evaluated if that happens, because it certainly could contribute. If you have some other condition that's, for example, if your parathyroid gland, which is a gland in your neck, is too high, it can make your calcium too high, and that can worsen this problem. If you're taking too much vitamin D and your vitamin D level is toxic, that's also going to add to the problem. But in general, this is not something that happens because of high levels in the bloodstream. There's people who have calcinosis and their calcium levels are low in the bloodstream and their phosphorus levels are low. It's not because there's too much. It's a local process happening in the tissue. And I'm going to talk about where it starts. But it's not necessarily a bloodstream process. It's something happening at these individual areas. There's another condition called heterotopic ossification. Heterotopic means where it's not supposed to be. Ossification is bone formation. That's a separate condition. So heterotopic ossification often affects children. And when those people get excess calcium formation, it looks like bone. In scleroderma, usually these deposits don't look exactly like bone. They look unusual. They don't look like well-formed bone, and I'll show you what they look like. But there are some similar features to bone. And it is a calcium phosphate crystal deposit in the soft tissue. There's different kinds of crystals that can actually deposit. When you get into the nitty-gritty of the chemistry of it, there's sometimes been different crystals that are identified. But in general, these are something called hydroxyapatite. The most common area of the body to be affected by calcinosis is far and above the hands. And specifically, the specific finger that's most likely to be affected is the thumb of the dominant hand, which is the worst place to be affected. So if you're right-handed, it's going to go for your right thumb. If you're left-handed, it's going to go for your left thumb. We were just talking, it often, back in the days when people used to write more with pencils, which now we've kind of moved away from this, we used to see it a lot where people would hold their pens. It's funny, as people type more, I think we're seeing less of that pen holding calcinosis, but often people would have it right where they hold that pen, right here, thumb in the middle or thumb in the index, depending on where you hold your pen. And so what we can see here, looking through, I put the arrows where the calcinosis is. And so you can imagine you put your right hand over this x-ray, these fluffy white spots over there, those are all the extra calcinosis areas. So in this x-ray, we see a ton of it at the thumb. We see some of it at the tip of what we call the fourth finger, or the ring finger. Then we see a lot of it around the middle finger. It often seems to pop up where the tendons insert or where the joints are. Scleroderma-related calcinosis has a predilection, a preference to go for the joints. Again, the worst place you can go for. So the elbow is another common area where we see a lot of calcinosis. And this one is a bear because you put your arm down to go type and you've got calcinosis there. And so you don't realize how many times you put your elbow down until you've got something there that hurts when you put it down. When calcinosis gets bad, there actually are some studies showing. There's like a, okay. When calcinosis gets bad, it can actually pinch the nerves. So, and we see this in a couple different areas. So we commonly see these pinched nerves when there's a lot of calcinosis around the elbow. So there's a condition called ulnar neuropathy, where people get numbness, tingling, weakness on the pinky side of the hand. So that can occur when people get calcinosis there. Another place where we see pinched nerves happening is when people have a lot of calcinosis around the hips. There is a nerve called the lateral femoral cutaneous nerve that wraps around the hip that can get pinched when there's calcinosis around the hip. And so people can get numbness along the front of their thigh where it pinches. Same thing in the knee. So the nerves are very close to the surface around the knee. If there's a lot of calcinosis around the knee, sometimes a nerve called the peroneal nerve can get pinched. And there can be what's called a foot drop, where it's hard to pick your foot up and it slaps as you walk and you can trip and fall. So it's not just an issue of comfort. Sometimes there actually can be nerve compression that happens. One of the other issues with calcinosis, especially that it occurs around the joints, is that joints bend and joints don't have a lot of give. Now, if you have calcinosis in your thigh, that skin can stretch a little bit. If you have calcinosis around your elbow, on your finger, there is not a lot of give in those areas. So when the skin stretches, it gets thinner and it has a tendency to break open. So when you have calcinosis under there that's stretching these areas, sometimes the skin can break down. And when it breaks down, that knee has to bend every day. And you can't necessarily immobilize it without causing damage. So when you're bending constantly, it takes a long time for these areas to heal. So sometimes the calcinosis itself can just open up and leave chronic draining wounds. So one of the things with calcinosis that you'll all probably know better than a lot of our trainees and physicians is that if you want to know where calcinosis is, just ask the patient. Because typically when I'm examining, I may see one, maybe kind of the tip of the iceberg. But often that calcinosis can wrap around the muscles. So here you can see a couple little deposits, but that is actually a sheet of calcium based along the forearm muscles. And we'll often see that when people have elbow calcinosis, it will extend into the forearm and wrap in the muscles. Why are these areas so affected? So this is something that we studied in mice, and we also have looked at in people, and I've looked at a lot of different scans. And I will tell you, this is the Dr. Richardson theory here, but I've looked at scans years before someone's developed calcinosis when they've gotten an MRI because they had pain. They had pain first, calcinosis developed later. And what was there in that MRI before they ever got calcinosis? Inflammation of the tendons and sometimes inflammation of the joints. So I'm convinced that that precedes the calcinosis in a lot of these cases, that it's caused by inflammation in the tendons and in the joints that then over time tries to heal but doesn't heal properly. And tendons have a high predisposition to becoming calcified. So if you look in people without scleroderma, over time, as people get older, often the rotator cuff tendons in the shoulder, they start to calcify. There are other tendons. Sometimes people get calcifications in the tendons on their foot without scleroderma. Tendons like to calcify. And often tendons are also places that are sensitive to mechanical stimulation. So when you stimulate a tendon, it has actually mechanically sensitive cells in there. So when we ask, why do we think that calcinosis is forming where people are putting pressure? What cells are responding to that kind of pressure? Tendon cells. So nobody really knows, but the best working hypothesis to me is that in people with scleroderma, this is an abnormal healing process. There are joints that are inflamed, there are tendons that are inflamed, and as things try to heal, they're not healing and going back to the original state. They're healing with calcifications there. Who is affected by calcinosis? It's really, really common. Up to 40% of people with scleroderma have calcinosis. The vast majority of people who have calcinosis will have a few deposits here and there. Some of these images that we're looking at, these are people with more extensive calcinosis, which I'm sure many people in the room, because you're coming to this talk, you may have that more extensive form. But in average, that is not the majority of people. So about 4% of people with scleroderma will get this more extensive calcinosis, what we call a heavy burden. And the people who are more likely to get that heavy burden of calcinosis are people who've had scleroderma for longer and they've had more complications of their scleroderma. So if you can think of it as a curve where there's an area under the curve where it's like scleroderma is marching on and there's more damage. If there's a bigger area under that curve, more time, more damage, more calcinosis builds up. There's certain specific risk factors for a lot of calcinosis that we've found in our studies too. So myositis, muscle inflammation, which I think is something that's really under-recognized in scleroderma. There's a lot of muscle involvement in scleroderma, and most rheumatologists don't routinely look for it. Here we do, but I would say it's something generally I think we need to have a higher awareness of, is that muscle inflammation in scleroderma. And PMSCL antibodies, these are specific antibodies that are, again, are not routinely checked for in most scleroderma labs. Most scleroderma labs, they're going to tell you what your ANA is. They're going to tell you what your centromere antibody is. They're going to tell you what your SCL70 antibodies. You may have to ask your rheumatologist to check more scleroderma antibodies. So RNA polymerase 3, PMSCL is one of the other antibodies that's not that common. About 5% of people with scleroderma have it, but when they have it, they're more likely to have myositis and they're more likely to have a lot of calcinosis. There are labs that you can access almost anywhere throughout the United States to have these checked. And so you can ask your rheumatologist or whoever's taking care of you. There are to send a panel to LabCorp or to Quest. And at Quest, it's the Scleroderma 12 antibodies panel. But all these commercial labs that are nationwide, a lot of them have full scleroderma panels. So you can find out if you don't have one of the major antibodies, you can find out if you have these, if you have a lot of calcinosis. So this is one of the studies that we did. And so this was in the Johns Hopkins cohort, which is an amazing group of people with scleroderma who's been coming to see largely, Fred Wigley started this cohort in the 70s. And, Fred Wigley's probably seen more people with scleroderma than anyone else in the world. He's just an amazing physician, a nice man. I'm sure many of you have probably actually seen him. But he started this group of people with scleroderma, and over time it has built up. So it's, I think, a testament to the power of what you can do when you all get together and, people, give their permission to have their data, looked at in this registry. And so at the time I did this, there were over 3,000 people in the registry. And what we did is we actually used a machine learning tool. And, machine learning, it's all the rage now, but it's a really cool way of trying to figure something out without having your own preconceptions bias the results. So, sometimes in research, we ask a question and we ask the question in such a way that we know what answer we're going to get. You don't want to do that. So when you do research, you want to ask a question and be open to whatever answer you're going to get. So the first question that we asked in the study was, are there different groups of people with scleroderma? So within the broader group of people with scleroderma, are there smaller groups of people who look more like each other than like the broader group? And the answer was a very clear yes. So the groups that we were able to identify, which are represented here by the colors, and I'm going to walk you through, I know that the text is small, but the groups that we were able to identify were, number one, there was a very small group of people who didn't look like they had scleroderma, but they had very minimal complications. So they had no skin thickening, and they overall on the inside had very few internal organ complications. So they maybe had antibodies for scleroderma, Raynaud's, but overall we're doing quite well. There was the biggest group that we had was people who had limited skin. So skin maybe past the elbows, down below the knees, affecting the face. And overall on the inside, not a lot of complications. There were some complications, but overall doing fairly well, but had more skin involvement than the other smaller group. And then we saw two groups of people with a lot of skin thickening. So one group of people had a lot of skin thickening, but on the inside, not a lot of lung disease, not a lot of heart disease. So on the outside, lots of skin, but in the inside, not too many complications. And that group of people was more likely to be positive for RNA polymerase 3. The other group had a lot of skin thickening on the outside and a lot of organ involvement on the inside. So that group was more likely to be SCL70 positive, although not everybody was. So there's these four groups, and they separate really out by how much skin is there in terms of skin thickening and how much internal organ involvement was there. And the group in orange that you see is the group that had the highest chance of having calcinosis. So these on the bottom are scleroderma complications. So we have lung disease, kidney involvement, pulmonary hypertension, cardiac involvement, GI, myositis, joint disease, tendon friction rubs, Raynaud's phenomenon, and then we have cancer, which is another thing we see in some types of scleroderma. And what we see, these patients with a lot of calcinosis, they had more kidney involvement, more pulmonary hypertension, more heart involvement, more GI involvement, more muscle involvement. They had more tendon friction rubs, worse Raynaud's across the board. Everything was worse. So again, going back to that thought of, is this just the consequence of scleroderma being really bad over time? So again, that hypothesis, there's a thought that there may be some scleroderma-related inflammation plus low blood flow, because we know that cells that behave like bone cells can live in a low oxygen environment. So when we have tissue that's not getting adequate blood flow, cells may behave more like bone cells. And certain tissues may be more predisposed to that than others. So muscle tissue may be more predisposed to that kind of reaction. Tendon tissue may be more predisposed to that kind of reaction. When we did our experiments in mice to see if we could make mice calcify, the muscles did, but the skin did not. So there are tissues that seem more inclined to behave like bone cells than others. Okay, so here's a visual schematic of that hypothesis. So on the left, you have inflammation, you have tissue hypoxia, a low oxygen state, and then you have fibrosis. And interestingly, TGF-beta, which is a cytokine, it's a protein that causes skin fibrosis. It's kind of like the end pathway of a lot of what happens in scleroderma, is something that actually can promote calcification. And so at the tissue level, we think that you're getting loss of certain proteins that make the tissue behave normally. So certain calcification inhibitors, there's loss of stem cells. And then the end product of that is that calcinosis forms. Okay, this is like, I'm not even sure, why does in this audience, I think we know why calcinosis matters, right? Though we need a cure for it. We need to be able to reverse it. We need to be able to stop it. It's disabling, it's disfiguring. We don't have an FDA approved medication. But one of the other things beyond scleroderma, so it's really interesting. So there's been a couple studies showing that calcinosis in scleroderma patients is associated with certain types of things that we don't think about as calcinosis. So calcinosis in scleroderma is associated with more calcifications of the spine that look like wear and tear arthritis. So when we talk about wear and tear arthritis that happens in people without scleroderma, does some of that resemble what's happening in scleroderma-related calcification? Okay, we talked about that rotator cuff, when people get calcifications of the rotator cuff as they get older. If we were to understand how calcification forms in scleroderma, could we then apply that to people who are getting rotator cuff problems, which is the majority of people in the United States, and use that to help people even without scleroderma, right? And then calcification in the arteries, it's the same crystal as what we see in scleroderma. It may have some shared pathophysiology, some shared pathways that cause hardening of the arteries as scleroderma. And in people with scleroderma, what we see is that people with calcinosis, they're more likely to have aortic valve calcifications. Again, really common problem in people without scleroderma. So if we could understand why this is happening in this condition, could we understand what's happening in other conditions that are extremely common? And then, one of the most devastating things that can happen with people with scleroderma-related calcinosis is that they get infected, and they require surgery. And surgeons do not like to operate on calcinosis. They will operate if it gets infected, but then really, often it involves skin grafts, debridement, multiple, it's many, many months of recovery. And, again, just simple, sometimes we think about fingers being affected, but you talk about this is a calcinosis on the back. How do you sleep with this, right? So it's not just the broader understanding. It's not just about science. It's about, being able to live a good life. Okay. So the science of calcinosis, we already started in on it a little bit. We're going to delve a little bit deeper. So when we talked about calcinosis not being heterotopic ossification, which, heterotopic ossification being bone that forms outside of where it should. This is a 3D CT scan of calcinosis that occurs around the hips. And I can tell you, it is something a lot of times people with scleroderma are told, well, you have you have osteoarthritis, you have wear and tear arthritis in the hips because your hip hurts, right? Typically hip pain, it cuts across the groin, and hip pain from typical wear and tear arthritis. Scleroderma related calcinosis, if you take care of a lot of people with scleroderma, it has a different quality. Sometimes people will say it feels like it's in the tendons. It feels like it feels more in the front of the thigh. It feels like it's in multiple areas. And this may even not be palpable on exam. So someone may examine a person with this type of calcinosis and not be aware that there's anything wrong unless you did an x-ray or something else to have a look. And this is somebody with PMSCL, so it's a more severe type of calcinosis. But what you can see here is here on the side, you see the thigh bones, you see the pelvis, and then these areas that look like almost like candle wax strippings, that is calcinosis. So, the bone is smooth, it almost looks shiny on this 3D CT scan, it's organized. But these calcinosis deposits, they're not organized. They're kind of associated with where the joints and the tendons attach on the pelvis, but they don't quite look like bone. There are some similarities though. So bone-associated proteins have been shown to be present in calcinosis deposits. And then, if you were to have low bone density, your physician would tell you, you gotta do weight-bearing exercise, right? You've got to walk, you've got to stimulate that bone to grow. Well, calcinosis, when you put that mechanical loading on a calcinosis deposit, it likes to grow too. So that's another thing that they have in common. So this was a study that was done at Lurie Children. So this one, it showed they looked at calcinosis deposits. Actually, these were children with dermatomyositis, and they looked to see what proteins were in there. And all these letters here are names of bone-associated proteins. So osteopontin, OPN, osteonectin, ON, osteocalcin, RUNX2, which is kind of the master regulator of bone formation. So alkaline phosphatase. So all these are bone-associated, and there are some actually tooth-associated proteins like dentin phosphoprotein and dentin matrix protein, DPP, DMP1, and they were present in the deposits. That should not be so. In normal skin, you should not be seeing dentin matrix protein in your skin. But here in these calcinosis deposits, we do see it. And then what's interesting is they also saw some of these markers of bone-associated proteins in the blood vessels next to them. So the blood vessels are doing something that they're not supposed to be doing. And remember, in that slide, we showed that calcinosis is associated with vascular issues like Raynaud's, pulmonary hypertension. We do see more vascular issues in people with scleroderma-related calcinosis. So something's happening in the blood vessels that shouldn't be happening. And then we see these deposits outside as well. So another similarity between calcinosis and bone formation is that the crystal is the same. So in general, this is something called apatite. Apatite is a type of calcium phosphorus crystal. It forms a complex structure. It is not just calcium and phosphorus forming a salt, coming together and linking up and doing nothing. Hydroxyapatite is something that needs to be actively formed by cells that are behaving like bone cells. If we were to take a biopsy, and I've seen this all the time, so, there's many people with scleroderma, that get misdiagnosed with a lot of things at a lot of points in their time course. And so I've seen some of these biopsy slides come back as morphia, which basically is scleroderma with dystrophic calcification. So just calcium spots in a collagen matrix. Okay. Some look like liquid, and I've seen people think, oh, are these infected? It comes out like a toothpaste. And that's what calcinosis can do. Sometimes calcinosis is part liquid, it's part solid. Sometimes they pop out and they look like bone. Sometimes they look almost like sand or gritty. And in studies, what we've seen is that there are certain cells called macrophages, which are, macrophage, literally macro is big, phage is eater. So it's literally big eater cells and that are in there. They may be actually trying to eat those calcium deposits to get rid of them. They may not be the problem. They may be responding to the problem and making it worse. And then there have been some studies showing that there's some cells, but in general, the calcinosis is often, we don't see a lot of cells in there. So this is just an example from a published study, just showing what calcinosis looks like under the microscope. That black staining is the calcium staining. And here in those little black dots are the macrophages, so those big eater cells. Measuring calcinosis is a really important part of how we can figure out whether a treatment is working. And that is still an area of study. So there is a published measure of how to measure calcinosis in the hands. There is not a published measure of how to measure calcinosis definitively throughout the body. So x-rays are good as a first glance for just giving you an image. Most calcium deposits will light up on an x-ray. So that is a good first step. And you can measure things on an x-ray. Remember, you only get a 2D view. You know, maybe if you get a side-to-side view, you can kind of get 2 views. 3D CT provides a 3D view. So you can basically look at multiple dimensions, get a sense of the volume of the deposits. We don't routinely do this, but in certain situations that may happen. You know, this is more of a research study. And then one of the things that our group has looked at and another group has published is also the sodium fluoro PET scan, which is, again, not part of routine clinical practice, but I think may give us more information about areas of calcinosis that are just staying there, areas of calcinosis that are growing, areas of calcinosis that might be there in the future. So this is from our study. So we looked at the sodium fluoro PET scans. We did 3 in people with scleroderma, 3 in people with dermatomyositis, which patients get a lot of calcinosis there. And so what's interesting here is that here's the knee. And in part A, you'll see that there's an area of calcinosis that's right in front of the knee that you can see. You would be able to see this on an x-ray. You could see it on a CAT scan. In parts B and C, in part B, it's in black at the back of the knee. In part C, it's that yellow dot with the red arrowhead. And what it shows is that there's an area in the back of the knee that you can't see on a CT that's there on the sodium fluoro PET. So is this an area that's going to turn into calcinosis in the future? Because the sodium fluoro PET shows us what parts are taking up calcium. So you can see here, the knee bones light up. It looks like a horseshoe there. That's the knee bone. That's normal. Bone should be active because it's taking up calcium. But in general, the skin and the muscles should not be really taking up calcium. So that's an abnormal area that's starting to calcify. Right. So if you look at what's the difference between how much calcinosis we can see on a traditional scan and how much maybe on a sodium fluoro PET or how much we may be missing, here's a great example. On the left, those areas in white where I have the arrows, those are areas of calcification, calcinosis. But if we look on the sodium fluoro PET, all those areas in yellow, they are hot. So this is all around the pelvis. And so there is so much activity here that we're not able to even see yet. And this to me would be the time to intervene, right? Is something that actively growing. This is concerning that in the future, there's going to be a lot more calcinosis. And here's an example around the thighs. Again, you know, you see all these areas of activity around the thighs. So treatments. So when we talk about intervening, I wish we had a randomized clinical trial showing what treatments work for calcinosis. We do not. And so there are some things that we always recommend as standard of care therapy. There's some things that we offer on an experimental basis. And because the evidence is really, you know, there's published reports, there's case series, but a case series is not a randomized controlled trial of this medication versus a sugar pill. And there's a lot of, quite frankly, physician bias that goes into assessing this. Somebody may want the treatment to work, and the doctor may say, oh, I think it's working because I really want it to work. But that's not ideally the way you should be doing things. So, but this is the evidence base for a lot of what we use. It is kind of, you know, we do try to use some of these imaging studies to see for sure that it's working or not. But really, you know, the randomized clinical trials are lacking. So the treatments that we use for calcinosis at Northwestern, and there are a variety, and then we may consider in different situations, almost everyone, you know, the ones in red there. So treatment from, or protection from mechanical injury. And I have slides devoted to, so this is kind of the overview. And then we have treatment of ongoing inflammatory activity in the joints or muscles. So physicians think that 15% of people with scleroderma have inflammatory arthritis. I would love to do a poll. It's hard to do in a room with this big, but the actual number of how many people with scleroderma have inflammatory arthritis, like rheumatoid arthritis, is actually 50% on an ultrasound. So we miss a lot of it. I think sometimes people with scleroderma come in, everybody's so focused on the skin and lungs, you forget about the joints, you forget about the muscles. So we really try to look at what is active. Are there things that need to be treated? And some of these are really targeted towards that. So, right. So people, people with calcinosis are more likely to have arthritis in the joints, and a lot of that is inflammation. So can we address the inflammation that's happening, right? And sometimes that makes a big difference. So some of the things like methotrexate, sulfasalazine, low-dose prednisone, there's risks and benefits to everything. We always have to be mindful of steroids and scleroderma, but some of these things can make a difference in terms of how people feel. So surgical resection in select cases may be appropriate. There's sodium thiosulfate, which can be topical or injected. Usually we'll use the topical form. We rarely use the injectable form. Tofacitinib, which is the brand name is Xeljanz, anakinra, Kineret. This is actually something at the NIH that they've used quite a bit. And then the non-steroidal anti-inflammatories, there's a medication called minocycline, colchicine. Okay, so we're going to go through some of these in more detail with the time we have left. And I do want to make sure we have time for questions too. So this is actually perfect. Okay, so going back to that slide of the study we did, would treating scleroderma better eliminate calcinosis? I would sure hope so. I think the goal of this organization and the goal of a lot of our centers is to find a cure, right? Is no more scleroderma, no more progression. Maybe there's damage from what has happened with the scleroderma, but we want to stop scleroderma. And I would love to see, if we stop scleroderma, would people still get calcinosis? My guess is that the answer would hopefully be no, or maybe minimal calcinosis afterwards. But we're not quite there yet. I'm hoping that some of the things in the future might bring us to this level where we can actually do a study and say, hey, are people getting calcinosis anymore? Because the treatments we have right now are largely aimed at slowing the progression of the disease. And some of them are effective, at slowing progression, but we're aiming for cure. What you can do to treat scleroderma better and what you can help your rheumatologist with is, for example, people with weakness with scleroderma, make sure you get that CK level checked. It's a very simple blood test. And it's something that can, if you're getting a chemistry panel to check your kidney function, especially if you're having difficulty getting up out of a chair or a couch, or if you can't raise your arms to wash your hair, that could be there's some myositis underneath. Okay. And so if there is myositis, we'll often treat that pretty aggressively. There's medications like IVIG and rituximab that can be helpful for treating myositis. And again, if that arthritis, if you're having stiffness in the morning lasting more than 30 to 60 minutes, that could be a sign that there's inflammation in the joints. And so there are musculoskeletal ultrasounds that you can do to identify inflammation, because sometimes the skin is so tight that your rheumatologist may not be able to feel that joint inflammation. So that's where sometimes an ultrasound can help, because they can actually get through that scan, look at the sound waves, look at the joint, and they can see if there's, swelling around the joint. They can see if there's excess blood flow around the joint. And then you do want to maximize the blood flow to the areas, because blood flow helps with tissue healing. And so in general, it's always a good idea with the Raynaud's, if you're having digital ulcers, anything that shows that there's low blood, keep your hands warm, the heated vest, the heated pouch, medications, but you really want to maximize the blood flow. So how do you protect from mechanical injury? This slide, this was a little horrifying. This was something from Walmart. These finger cots. I love the finger cots. They're these little sleeves that go over the fingers. They're really helpful. You can get them, they're cotton blend. You can get silicone ones that are a little bit thicker. Please don't use a razor blade on your thumb to try to test if they actually work. I think this seems like a bad suggestion here. But maybe effective advertisement. Okay, so finger cuts can be helpful, especially if you have one or two fingers that's just really aggravating. The silicone blend ones they are thicker and they're perforated. And so sometimes those can be really helpful. They're just more of a cushion. A lot of people just use the adhesive bandages though, especially for ones that are around the knuckles. An adhesive bandage, I think that often works pretty well. We have people remove them at night just so that the area isn't kind of moist all day. But especially, when people have contracture, if you have contractures and your fingers are bent and you got a calcinosis there and you're trying to reach into a drawer to get a piece of silverware, that it's going to bump, right? So you want to avoid it bumping, not only because you want to minimize the progression of the calcinosis, but also because you don't want that area to open up and cause an infection. Okay, armrest cushions, if you're a computer user, and then chair cushions, you can custom fit those. You can use the egg crate and cut out a hole, if you have calcinosis around the pelvis. But, and people have I've seen people invent some pretty creative setups for taking pressure off certain areas. So that's for everybody, is cushioning the area. Surgical removal. So there are some studies showing that surgical removal goes better than physicians think it will for people with calcinosis. But my general experience is that the surgeons hate operating on calcinosis. It is, and they will go, and I've had surgeons, they will offer surgery and say, but your finger might get amputated, it might get infected. And nobody, who wants to do it then, right? Like, I don't want to lose a finger. And so they're just very, very reluctant. And I would say surgical removal, a lot of these deposits, like I said, they're like a tip of the iceberg. And so the ones in the hips, often we don't touch because that's an area there's a lot of bacteria in the hip area or in the buttock area. The ones on the knees and on the shins, I don't like to touch because the skin is so tight there in general. There's so much movement. Healing is really, really difficult. I've seen some of these stay open for months. Elbows are also tough. Elbows, sometimes you do the calcinosis resection, it's open for years. I've seen them drain for years. I kid you not. Where it can be helpful, sometimes a small bothersome deposit at the tip of a finger, right? So a little area that the surgeon can go in to make a small incision, pop it out. So sodium thiosulfate is something I also use for small localized deposits. And so this is something that your rheumatologist could order. So there's compounding pharmacies that can ship this. And so Mayo Clinic has a compounding pharmacy that we sometimes use. Here in Illinois, we have our own compounding pharmacies that are fairly local, but every state has compounding pharmacies. So sodium thiosulfate was actually studied in a Mayo Clinic series. It's, again, randomized controlled trials, no, but there is decent evidence behind it where they looked in a series of patients and they looked to see how many patients benefited. And they thought that about 75% of people had some improvement with their calcinosis with twice daily application of the sodium thiosulfate. It's a cream, goes right on the skin, use a small area to where you have the calcinosis. Sometimes it makes them kind of irritated and almost liquefy and come to the surface and they can pop out. But it is something, other than skin burning and then, potentially making that calcinosis come to the surface, it's generally fairly safe. It's not a pill that you have to take. So a lot of people do try this. It's usually not covered by insurance. And so it is, and it basically how it works is it prevents the calcium crystals from clumping together. It enhances their solubility. It doesn't stop the whole underlying process. And so, here too, the prescription it's like a 25% sodium. You need a prescription for it, but it's 25% sodium thiosulfate and it's compounded in zinc oxide or vanicream, which are just basically like a neutral base. And so, it's easy to just send into a compounding pharmacy. And if your rheumatologist wants to know more about it, they can, send me a message or something. So, okay. So Xeljanz, and I put this second, not because it's the second thing that we use, but because of all the things that I'm listing in this treatment part, it's probably the thing I've found most helpful. So the reason why I started using it was because Julie Pack at Johns Hopkins did a clinical trial in people with dermatomyositis for myositis and found that this seemed to be helpful for people with calcinosis. So we've offered it to people off label who also have arthritis, inflammatory arthritis, because Xeljanz is FDA approved for people with rheumatoid arthritis and other conditions as well. And so if we're treating the rheumatoid arthritis, sometimes we'll give this a try to see if this helps with the calcinosis. And I found it to be really helpful. And I've seen some areas where there's chronic, open, draining calcinosis, liquid deposits. Again, that chronic open elbow wound for years closed up on Xeljanz. And randomized controlled trials. We need randomized controlled trials. This is not the highest level of evidence, but it is something I've used in clinical practice and I'm using more and more. So it's called a JAK inhibitor. It's not a biologic medication like some of these injectables, but it still is very powerful. And so even though it's not injectable, it's a pill, it's actually a higher infection risk than some of the things like Humira and Enbrel. So that, it has to be something that you have to keep in mind with this. It's not, just a nothing medication. And so I've used the rheumatoid arthritis dosing, which is 5 milligrams twice daily. I avoid using that 11 milligrams daily because, there's just a slightly higher risk of blood clots with that. But, and then there are some, in extreme situations, you can use more. There's the higher doses FDA approved for things like inflammatory bowel disease. Okay, so talked about infection risk is a big deal with Xeljanz. And so it is something, and this is general guidance that if you're going on Xeljanz, the shingles risk is so high with Xeljanz, we always make sure people get at least one dose of the shingles vaccine before they start. And even that's for people under 50 as well, because that risk is so increased. And then it needs lab monitoring. It can affect the cholesterol profile in a negative way. It can cause low white blood cell count, elevated liver enzymes. So it requires blood work monitoring. And then everything, you're going to read the black box warnings. Everything has side effects. Everything has side effects. Okay, so cancer risk, cardiovascular risk, blood clot risk. So these are all things, again, calcinosis, it's that bad, right? For some people, calcinosis is life-threatening. Calcinosis, if it's constantly opening up and leaving people prone to infection, I don't love using an immunosuppressant, but sometimes we have to weigh what are our options here. Okay. Minocycline is it's a common medication. I can't say it's the most effective thing, but it is something that we will often offer people. It's not commonly used as an antibiotic, but it is one of these anti-inflammatory antibiotics. And in previous years, it used to be used more for rheumatoid arthritis because of the anti-inflammatory properties. It's not really used anymore. So often use 50 to 100 milligrams daily. And again, may have some benefits for inflammatory arthritis. Big side effect with minocycline is that it will turn your nails blue. So, and sometimes your, around the mouth or other areas turn blue or gray, and it's permanent. So it's like a permanent discoloration or staining. So, and sometimes it turns the calcinosis like a bluish gray too. So some of the calcinosis comes out and it's like gray and everybody panics, but it's minocycline actually staining the calcinosis. There is a rare risk of drug-induced autoimmune disease with this. So, it can cause a vasculitis. So again, risks and benefits. Colchicine is a common condition, or a common medication that we'll use. It is often used for gout. It's an anti-inflammatory. It blocks neutrophils, which are inflammatory cells, from migrating to the sites of inflammation. And so, the common side effect would be diarrhea with this, and you never get the side effects that you want. So if you're constipated, you won't get the diarrhea, right? Like, because some people are like, I would love to have the diarrhea, and you never get the side effects you want. But typical dose would be like 0.6 to up to 1.2 milligrams daily. I don't often use doses that are higher. It's hard for the GI tract to tolerate. But it's a reasonably safe option that sometimes we do give a try because it sometimes can help with that crystal-induced inflammation. Anakinra, I don't use a lot, but I have a couple patients that we've used this. So this is actually something, we use it for gout. So again, it's helpful for other crystal-induced inflammation. There's a condition caused by calcium crystals called pseudogout that we will sometimes use this medication for. It is a daily injection. And so and you can mark how many injections you've had, typically by the number of injection site reactions. And so when people give this, they may have, it's daily, and you may have injection site reactions, red marks from the past 20 injections. People don't love this medication. But, for people with really bad inflammatory calcinosis, sometimes we do. And sometimes giving yourself a daily injection that will leave a welt is better than not doing something. Non-steroidal anti-inflammatories, these are commonly used. A lot of them are over the counter. Don't forget that they have side effects, right? So kidney disease, for people early in scleroderma, they can increase the risk of renal crisis. So always talk to your doctor before taking something over the counter. Even something like ibuprofen, especially people who have GI issues, they can cause GI bleeding. For people who have problems taking oral non-steroidal anti-inflammatories, Voltaren gel can be helpful. And so it has really minimal absorption. So sometimes we'll use that to the intact skin. It's an anti-inflammatory that can help with joint pain. And okay, so we talked about calcinosis and bone. how does calcinosis interplay with the actual bone that you're supposed to have in your skeleton? Well, the catch-22 with calcinosis is that as people are getting calcium where it shouldn't be, they're getting lower bone mineral density. So there is an association between more calcinosis and worse bone density. And so if you have calcinosis, and especially if you're postmenopausal, you need a bone density screening anyway. So, but it is probably something to talk to your rheumatologist. Scleroderma itself can increase your risk of fracture. And then calcinosis can potentially be a risk factor. And all these don't get factored into the traditional screening tools for, or the risk assessment tools for bone density. So when you calculate your fracture risk and a bone density, scleroderma is not in there. So scleroderma does raise your fracture risk. It just, it's not on the routine calculators we used. And so, you know, again, keeping aware of bone health. I don't tell people not to take calcium and vitamin D because you may need that for your bones. And it's not clear that that really worsens calcinosis. But it is something you don't want to be taking super high doses of vitamin D where your calcium levels might go up. And then if you need something for your bone health, you know, the endocrinologists at our center typically try to avoid using Forteo teriparatide, which is a bone building agent for in people with calcinosis. How much is that evidence-based? I'm not sure. That is, you know, one of these practices that we have here. You know, often people with scleroderma are more likely to be on something like Reclast, which is an IV bisphosphonate infusion. But I do still recommend treating, you know, if your fracture risk is high, or if you have osteoporosis, I still do recommend treating, even if you have calcinosis. So key points. Everyone with calcinosis should take care to cushion the areas of calcinosis. You know, that's very simple, you know, no medication, you know, always make sure you're kind of minimizing that mechanical pressure and making sure to avoid skin breakdown. Treat the underlying scleroderma activity as well as possible, with the caveat that, you know, the treatments may not be perfect right now and we're working on better things, but do the best you can to try to make sure, you know, different complications are addressed. Mycophenolate may be working for your lungs, but it may not work for muscle. So certain medications may work for one thing, but not another. Mycophenolate often does not work for arthritis. And so it is something that even if you're on an immune suppressive medication, if you're still having symptoms of other manifestations of scleroderma, you may need more treatment for those. And then topical sodium thiosulfate cream can be helpful for mild deposits. I very frequently do give that a try. And again, the average that people needed to use it before they noticed that benefit was about 4 months in that study. And then tofacitinib, Xeljanz, you know, that is something that, you know, I reserve for really severe, you know, active cases of calcinosis. Very, very careful conversation about risks and benefit. I do use the other treatments as well. But like I said, I think that is probably the thing I've found to be most effective in my practice. Okay, so this is the Northwestern Scleroderma Program. This is actually, there's people missing from this slide, but, you know, it's a community effort. And, you know, so if you're out here in Chicago, you know, love to come see you. And then thank you and have a wonderful conference. And we have about 10 minutes for questions, which is, 6 minutes for questions. So this is perfect. And so, I don't know.